Welcome to the deep dive. We take your source material, dig into it, and pull out the most important insights, basically giving you that shortcut to being genuinely well-informed.
Think of us as your guides, navigating through the information you've shared with us.
And today, we're tackling something really fundamental for understanding circulation outside the heart. It's peripheral vascular assessment.
Yeah, you gave us this chapter, and it really lays out how healthcare pros systematically check everything: arteries, veins, lymphatics, in the limbs, away from the core.
It's quite detailed. Starts with talking to the patient, then looking, feeling, listening.
Exactly. And our goal here, our mission for this deep dive, is to unpack those key steps from the text. We want to focus on what exactly professionals are looking for, what they're listening for. Right. What signs, what sounds, what things the patient says, tell them what's happening with blood flow out there.
It's kind of like getting a guided tour of the body's vascular highway system and learning how the experts spot, potential traffic jams or detours before they cause a big problem. Okay, let's get into it then.
Let's do it.
So let's start where the source starts the core purpose. It calls this assessment the foundation for, well, everything that follows.
That's right. It's the base for deciding on treatments, what tests might be needed next, even nursing diagnoses. It really is step one in figuring out what's going on with circulation in the arms and legs.
And it's not just about one thing. The source mentions using all the senses: looking, feeling.
Tactile, listening, auditory, even smell, olfactory. Which, makes sense if you think about potential wound odors or tissue issues.
Plus nonverbal cues from the patient, too.
Absolutely. That multisensory thing is key. And another really critical point the source stresses over and over is comparing things bilaterally.
Meaning side to side.
Exactly.
Yeah.
Check the pulse on the left, check it on the right. Is one leg warmer? Is one more swollen? That comparison, that search for asymmetry is just crucial for spotting problems.
Makes sense. And even before you start the hands-on stuff, there's preparation.
Oh, definitely. Getting the environment right is important. Good light, so you can actually see subtle color changes. A warm room, because being cold clamps down circulation, right?
And affects comfort, yeah. Privacy, too, and keeping things quiet for when you need to listen.
And prepping the patient is just as vital. The text emphasizes explaining what you're doing, what they might feel, making sure they're comfortable, that you can access their limbs easily. It's all about building trust, reducing anxiety.
Okay, so environment set, patients ready. Where does the actual assessment begin?
Well, it actually starts before you even touch the patient. The source puts a massive emphasis on the patient's story, the history. It literally says careful questioning is important, and the history is key to an accurate assessment. You learn so much just by listening.
That makes perfect sense. So what brought them in? The chief complaint.
Right. And the source gives a great framework for asking about symptoms. It's not just, does your leg hurt? It's way more specific.
Like, where is it? What's the pain? Like, the character? When did it start?
And what makes it worse? Stress, walking, certain meds. What makes it better? How often? How long does it last? Is it getting worse? It's like a mini investigation for each symptom.
Wow, that's thorough. And pain seems like a really big one for vascular problems, especially in the legs.
Oh, absolutely. The source goes deep into specific pain patterns that are really, really telling. You have to know how to differentiate them.
Okay, like intermittent claudication. That's the classic one, right?
It is. Described as an ache, maybe a cramp, or just tiredness in the muscle.
Yeah.
But the key things are, it comes on with exercise, and it's relieved by rest.
Okay.
The text explains it as basically not enough oxygen getting to the muscle when demand goes up. It even calls it angina of the leg.
Like chest pain, but in the leg muscles. Interesting.
Exactly. And here's a really important detail from the source.
Right.
The pain you feel is always further down the limb, distal, than the actual blockage.
So calf pain might mean a blockage higher up, like the thigh. That seems a bit counterintuitive.
It does, but it's a key diagnostic clue. Pain location points away from the occlusion site, downstream.
Got it. And the source even mentioned something about exercise to the point of pain maybe being helpful sometimes?
Yeah, it suggests that pushing to the point of claudication might actually help stimulate collateral circulation, the body trying to build natural bypasses around the blockage.
Okay, so that's pain with exercise relieved by rest. How does that compare to ischemic rest pain?
Well, that's a much more serious sign. Indicates more advanced disease. Ischemic rest pain is constant.
Not related to activity then?
No, completely unrelated to walking. It's often described as this hot, burning pain, usually in the foot, like across the ball of the foot. And it gets worse when you elevate the leg.
Because gravity isn't helping the blood flow.
Precisely. And it might feel a bit better if you hang the leg down. Dependency. Again, using gravity.
That sounds incredibly painful. Constant burning pain.
It is. And it signals severe arterial blockage. There's just not enough blood getting through even when the muscles are resting. The source links this kind of pain to other physical changes you often see, like thinning skin, maybe thick nails, hair loss on the leg, because those tissues just aren't getting nourished. It's a major warning sign. Can lead to gangrene if things don't improve.
Okay, so those are the big arterial pain types. The source also mentioned venous claudication and nocturnal cramps.
Right, briefly. Venous claudication is more of a bursting pain, often with swelling. And nocturnal muscle cramps, well, they happen at rest, often relieved by moving or massage, not necessarily arterial.
Gotcha. So beyond the specific symptoms like pain, the history involves looking at the bigger picture too. Risk factors, medical history.
Absolutely. The source lists a whole bunch of things that increase risk. Age, definitely over 60 is mentioned. Gender, ethnicity.
Male, gender, African-American ethnicity were noted.
Right. And, critically, existing conditions. Things like known atherosclerosis, diabetes, huge factor, hypertension, high cholesterol.
Low HDL, high triglycerides were specifically called out.
Yes. Also, any history of heart problems like angina or heart attack, kidney disease, these all play a role.
And lifestyle factors seem huge too.
Oh yeah, tobacco use is a big one, heavily emphasized. But also drug abuse, obesity, maybe jobs that involve standing all day, being sedentary, diet, alcohol, and family history too.
Yeah.
If your family has arterial or venous problems, your risk is higher.
It really paints a picture of the whole person.
It does. And checking current meds, even herbal stuff is part of it, because sometimes they can affect symptoms.
Okay, so you've gathered this incredibly detailed story. Then you move to the physical exam, what the body itself shows. Inspection, palpation, auscultation.
Seeing, feeling, listening.
Yeah.
Exactly. And across all of it, those core principles. Look for symmetry, use the back of your hand for temperature, always compare one side to the other.
Makes sense. Let's start where the source does, maybe surprisingly, with the head and neck.
Yeah, it seems a bit far from peripheral, but it's a quick, important check. Circulation issues, especially those affecting the big arteries going to the brain, can show up here.
So you're looking at orientation, vision, facial symmetry. Asymmetry could mean a stroke or something related.
It could be, yeah. Neurologic signs linked to circulation. You might even see a really bounding carotid pulse in the neck or jugular vein distension, JVD, especially with high blood pressure or heart failure.
And feeling the carotid pulse, the source had a specific warning there.
Yes. Crucial point. Only palpate one side at a time.
Why is that so important?
You risk cutting off or at least significantly reducing blood flow to the brain if you press on both simultaneously, especially if someone already has blockages. You check the rate, rhythm, the strength amplitude. A weak or absent pulse could mean a blockage higher up, maybe even in the aorta. You also feel facial and temporal pulses.
And listening in the neck. What are you listening for?
Carotid bruits. The source describes them as these abnormal, low-pitched crackling, whooshing, or windy sounds.
Whooshing.
Yeah. Use the bell of the stethoscope. Maybe ask the patient to hold their breath for a second. Signals turbulence, basically rough flow, usually because the artery is narrowed or irregular inside.
All right. Moving down to the arms, what are you inspecting there?
Again, size, symmetry, muscle tone, skin color, texture. Nails are important here too. The source mentions slow growth, dry, brittle, thick nails can be a sign of poor circulation.
You're looking for actual sores too.
Definitely. Lesions, ulcers, even gangrene on the fingers would indicate pretty severe ischemia. Also, if one arm is suddenly much more swollen than the other, that could point to a clot in the subclavian vein.
And specific conditions like Raynaud's?
You might see signs of it, those waxy, papering fingers, maybe tight-looking skin. Also checking for weakness or numbness in the hands.
And feeling the pulses in the arms. There are quite a few.
There are. The subclavian at the base of the neck, axillary in the armpit, brachial in the inner elbow, and then the ones most people know. Radial on the thumb side of the wrist, and ulnar on the pinky side.
And comparing volumes side to side is key again.
Always. The source mentions a grading scale too, 0 for absent, up to +4 for bounding. So it's not just yes or no, it's how strong.
What if you can't feel one?
You document it as absent to palpation, but importantly, you then use a handheld Doppler. It's like a little ultrasound probe. If you can hear the blood flow sound with the Doppler, the pulse is present, even if you can't feel it.
That's useful. Now, there was a specific test mentioned for the hand circulation. The Allen test.
Ah, yes, the Allen test. It's a neat little maneuver to check if both the radial and ulnar arteries are open and supplying the hand properly.
How does that work?
Okay, so you have the patient make a tight fist that pushes blood out of the hand. While they're doing that, you press down firmly on both the radial and ulnar arteries at their wrist.
Okay, cutting off the supply.
Right. Then the patient opens their hand. It should look pale, blanched. Then you release pressure on one of the arteries, let's say the radial. You watch how quickly the normal pink color returns to the palm. Should be quick, just a few seconds.
And then you repeat for the other artery.
Exactly. Compress both again, release the ulnar this time, and watch the color return. If the hand stays pale after you release one artery, it suggests the other artery, the one you're still holding, isn't contributing much. It might be blocked. It checks if each artery alone is enough.
That makes sense. Checks the redundancy. The source also mentioned feeling nodes near the elbow.
Yeah, the epitrochlear nodes, just above the inner elbow. Feeling for enlargement or tenderness could suggest infection or something else going on in the arm or hand.
And standard things like blood pressure in both arms, initially at least, and capillary refill.
Yep, capillary refill in the fingers. Press the nail bed, it goes white, let go. Color should flood back in under 3 seconds. Quick check of the tiny vessel circulation, the perfusion right at the fingertips.
Okay, moving down again to the abdomen. What's the vascular assessment focus here?
You're looking at the shape, any distension. Visible pulsations can sometimes be seen, especially in thinner people. Discoloration could hint at internal bleeding. And the source mentions something called blue toe syndrome.
Blue toes from an abdominal issue.
It's when tiny clots, emboli, break off from something like an aneurysm in the aorta, travel down the bloodstream, and lodge in the small vessels of the toes, causing these painful blue spots.
Wow. Okay. And feeling the abdomen, you actually palpate the aorta.
You do, in patients where it's feasible, usually not obese. You feel gently but firmly above the belly button. Normal wintus may be thumb-sized, but the key thing the source flags is if it feels wider than about 4 to 5 centimeters.
That's a red flag for an aneurysm.
Exactly, an abdominal aortic aneurysm, or AAA. You're also feeling for any tenderness over that area, which could mean it's leaking or at risk of rupturing.
And listening in the abdomen? For bruits again?
Yes, listening with the bell over different areas. You might hear them over the main aorta or iliac arteries lower down, or sometimes higher up, over the renal arteries supplying the kidneys.
Which the source linked to a specific type of high blood pressure?
Right, renovascular hypertension. Or you might hear bruits over the mesenteric arteries, which feed the intestines. That could be linked to intestinal angina pain after eating because the gut isn't getting enough blood.
Okay. Now for the legs, this seems like where a lot of the classic signs of peripheral vascular disease show up.
It often is, yeah. Inspection is huge here. Size, symmetry again, looking really carefully for swelling. Edema is at one leg or both. Any muscle wasting, atrophy, foot drop.
And color is really key in the legs, isn't it?
Crucial. Paleness, duskiness might mean poor arterial supply. Bluish color, cyanosis, or a mottled look could be poor venous return or really severe arterial lack of flow.
And you mentioned that specific sign, dependent rubor.
Yes, the source highlights that. It's a sign of chronic arterial problems. If you elevate the legs, they might go pale, but then when the patient dangles them down, dependency, the feet and lower legs, can turn this deep reddish-purple color. That's the rubor.
Why does that happen?
The thinking is it's chronic vasodilation. The small vessels are sort of permanently trying to open up as much as possible because they've been starved of oxygen for so long. You also look at hair distribution, often lost on the lower legs and feet with arterial disease. Skin texture might be thin, smooth, shiny. Nails, again, thick, brittle. And you look very carefully for any ulcers or gangrene, especially around the ankles, heels, and toes.
You also check veins when standing.
Yeah, looking for varicose veins, those dilated, twisted-looking ones.
And there's that test involving raising and lowering the legs.
Right. Elevate the legs for a bit, let the venous blood drain, note any pallor, then have them sit up and dangle the legs. You watch. How fast does the normal color come back? Should be under 10 seconds. And how quickly do the veins on the top of the foot fill up? Delays in either suggest arterial blockage.
Okay, feeling pulses in the legs. Which ones are we checking?
Start proximally with the femoral pulse in the groin. Then the popliteal, behind the knee. The source says this one is often difficult to find. It's deep in there. Then down to the ankle and foot. The posterior tibial, behind the inner ankle bone, called critical in diagnosis by the source, and the dorsalis pedis, on the top of the foot.
That's the one that might be missing normally in some people.
Exactly. About 5% of people are born without it, so you can't automatically assume it's a blockage if you don't find it. Good to know.
And again, symmetry, regularity, and using the Doppler if needed.
Absolutely. Especially for that popliteal, or maybe the pedal pulses if there's swelling or the patient is larger, the Doppler confirms flow is present.
And temperature check with the back of the hand.
Yep. Coldness, especially if one leg is colder than the other, strongly suggests arterial insufficiency. Warmth, on the other hand, might point towards venous issues like inflammation or a clot thrombophlebitis. You might also gently feel along veins for tenderness, another sign of thrombophlebitis, and check the inguinal lymph nodes in the groin.
What about edema? You mentioned looking for it, but there's grading too.
Right, edema grading. It's a scale, usually 0 to +4, to quantify how much swelling there is. You press gently over a bony area, like the shin, and see how deep the indentation is and how long it lasts. +1 is mild, disappears quickly. +4 is deep, lasts a long time, leg looks really swollen.
And does the pattern matter? One leg versus both?
Huge difference. Unilateral edema, just one leg, might suggest a local problem like a DVT, a deep vein clot, or maybe lymphatic blockage. Bilateral edema, both legs, is more likely something systemic heart failure, kidney problems, liver issues. The source also mentions Hohmann's sign.
Calf pain when you flex the foot.
Yeah, but it correctly points out it's really unreliable for diagnosing DVT and potentially risky because you could dislodge a clot. Most don't rely on it heavily now.
Okay. Now there's one more big test for the legs the source details, the Ankle Brachial Index, ABI. This sounds important.
It is really valuable, yeah. The source definitely highlights it. It's a simple, non-invasive way to compare blood pressure at the ankle with blood pressure in the arm.
And why is that comparison useful?
Because it gives you an objective measure of blood flow to the legs. Crucially, it can detect decreased flow, lower extremity arterial disease or lead, before someone has obvious symptoms like rest pain or ulcers. It helps diagnose lead early.
Okay, so how do you actually do it?
Well, the patient lies flat for a few minutes first. You take the blood pressure in both arms, standard cuff, and note the higher systolic reading.
Okay.
Then you put a cuff on the ankle. You use the handheld Doppler to find the pulse signal, either the dorsalis pedis on top of the foot or the posterior tibial behind the ankle, and you inflate the cuff until the signal disappears. Then slowly deflate it, noting the pressure when the sound returns. That's the ankle systolic pressure. You do this for both arteries in both ankles.
So you get arm pressures and ankle pressures. How do you get the index, the ratio?
You take the higher of the two systolic pressures you measured in one ankle, either DP or PT, and you divide it by the higher of the two systolic pressures you measured in the arms.
Ankle pressure divided by arm pressure. Got it. And what do the numbers mean?
So an ABI of 0.9 or higher is generally considered normal. Less than 0.9 suggests lead.
The lower the number, the worse the blockage?
Generally, yes. An ABI below 0.5 indicates severe ischemia, really poor blood flow, often linked to rest pain or tissue damage. And the source also mentions that a very high ABI, like over 1.3, isn't good either. It suggests the arteries are calcified and stiff, hard to compress, which you often see in people with long-standing diabetes.
So a lower ABI means higher risk, and it's useful for tracking things over time.
Exactly. It gives you a number, an objective baseline.
Yeah.
You can see if treatment is working or if the disease is progressing by checking the ABI periodically.
Wow. Okay. That really is a systematic journey, isn't it? From the patient's own words through all the looking, feeling, listening, it builds a really complete picture.
It really does. From how they describe their pain, is it that claudication with walking or the burning rest pain, to the examiner picking up on subtle things like less hair on the shins or how the skin feels? Every little detail is a clue.
And those specific findings we talked about, like that dependent rubor color change or just comparing pulses side to side, they can point you in the right direction immediately.
Plus the specific tests, like the Allen test for the hands or that ABI for the legs, they give you objective numbers, data that backs up your clinical impression.
And it all comes back to what the source said at the start. This isn't just finding problems, it's the foundation for figuring out the right treatment, improving someone's life, maybe even preventing really bad outcomes, like losing a limb.
Absolutely. And the source kind of summarizes the patterns nicely in its key points. You suspect arterial problems more with things like that dependent rubor, skin atrophy, coldness, weak or absent pulses, those specific pain types we discussed.
Claudication, rest pain.
Right. And ulcers or gangrene in bad cases. Whereas venous issues, you're thinking more along the lines of swelling, edema, maybe skin changes like flaking or brown staining around the ankles, warmth, maybe tenderness along a vein if it's inflamed.
Thrombophlebitis. And different pain patterns, more related to swelling or standing.
Exactly. It helps you sort of categorize the main problem. getting blood to the tissues or getting it back.
It provides a really clear framework for putting all the pieces together.
It does.
So reflecting on everything we've unpacked from this source, what really stands out to you? Just how intricate but essential this whole assessment process is.
Yeah, I think it really underscores how seemingly simple complaints, like someone saying their feet are cold or their legs hurt when they walk, can signal complex issues that need this kind of careful, systematic look. The body tells you so much if you know how to interpret the signs.
Definitely something to think about. How does understanding these specifics change how you might think about common things like leg pain or cold feet now? Something to ponder until our next deep dive.